In 2000, a young recruit just a few months into his military career developed pneumonia.
These young people had come in from all over the country.
And that pneumonia really started to take over his lungs.
They came in healthy, and now they were in the hospital, and their parents were very concerned, and their parents wanted to talk to their doctor.
Adenovirus infects the lower respiratory tract or lungs. You see an increase in inflammation and fluid. You're basically drowning. You're drowning in your own fluids. There's no treatment for that. The only thing you can do is support that person with ventilation. And other than that, you're just standing back and hoping for the best.
And so this young man, just 18 years old, died of adenovirus infection. It was the first death the military had recorded from adenovirus in 25 years.
Tonight, there is growing concern about measles spreading.
Measles cases in Texas.
More than 600 cases have been reported across 21
Measles
states.
was declared eliminated in 2000 in the United States.
25 years, we haven't really had to think about measles. We haven't had to think about vaccine-preventable childhood diseases because it's just gone. It was preventable. So now we're having to pivot our work again to focus on something that had been eradicated for 25 years.
Another child has died from the measles in Texas. The state reports this is the second.
When there's a public health emergency, we tend to get public health funded.
There's really a race to save lives, and it's the sense of panic. Someone has to do something. And usually even after that emergency ends, that feeling of panic really inspires decision makers to do things like make investments in public health infrastructure.
When there's nothing going on and public health is working and, prevention's happening, we don't see continued investment.
And we enter a period of neglect where we start to forget the reason why we made those investments, and we forget the experience of when things go wrong. And that's when we start to see a rollback in funding, in commitments, in vaccine coverage, for example, and over and over again, we enter this cycle of panic and neglect.
With measles, we have large supplies of the measles vaccine, which is wonderful because we can utilize it when we see an outbreak. But, there is that concern that access to all of these vaccines may disappear.
And that's exactly what happened with the adenovirus vaccine.
Coming out of World War I, the military realized it had to take control of respiratory viruses seriously. The 1918 pandemic influenza was hugely disruptive to military operations.
From the standpoint of the military, they want military readiness, and I think that anything that interferes with that is a problem.
If you've got 20% of your people being hospitalized, that's a large number of people.
So the military was actually well ahead of the civilian world in an interest in actually controlling these outbreaks and finding ways to keep troops healthy.
At that time, Walter Reed Army Institute of Research in Washington was the epicenter for all infectious disease research in the world.
Maurice Hilleman is a giant in the field of infectious diseases, and particularly in the field of vaccinology.
I was in charge of the central laboratory for the military worldwide surveillance for early detection of these viruses.
Virology as a field of study was really in its infancy. Influenza was the major focus, and a lot of the other viruses that we know cause flu-like illness hadn't been discovered yet.
My assignment was very simply learn everything you can about influenza and avert or prevent the next pandemic.
There was a respiratory death in Fort Leonard Wood. Dr. Hilleman was interested to see what was the cause of that, assuming it was most likely influenza virus.
I took a team out to Fort Leonard Wood to collect specimens.
Could this be a pandemic strain? Could this be the beginning of a next pandemic? And what he found, to his surprise, was that it wasn't influenza.
This was a blooper. We didn't have any influenza specimens. We had a new disease.
There were respiratory viruses that we didn't have a name for.
It had cost a lot of money. I had requisitioned a C-47 and all that kind of stuff. So I told my associate, Jackie Warner, I said, look, we got to do something. The obvious thing was to then take those throat washings from Leonard Wood, put them into cell culture and see whether one could grow a virus. So we made explant cultures. Out of this, we were able to grow epithelial cells that had cilia on them. Some days, everything just goes right. This was the discovery of the adenoviruses, causes acute respiratory disease, common cold, and atypical pneumonia in the military especially.
Adenovirus resulted in infections in probably 80% of the young recruits coming into the military, and about 20% of these people were hospitalized.
So it was really disruptive to the process of training new recruits.
The only way really to deal with adenovirus is to prevent it. That's it.
So I developed a vaccine. And I had that within 3 years after discovery.
Dr. Hillman wasn't the only person who was interested in this virus.
There was incredible cooperation between the NIH, the Walter Reed Army Institute of Research, the CDC.
Once Maurice had something to test, they set up clinical trials within the military populations, giving some troops this vaccine and some were left as a control. And then they would compare how many people became infected with adenovirus. And it was quickly clear that this was an effective vaccine. It was working to prevent adenovirus infection.
Within a relatively short period, from the time the adenoviruses were first identified back in the 50s to 1971, they were able to get an effective vaccine out there to training centers.
The fact that there was now a tool that could not just slow these outbreaks, but in many cases prevent them altogether, was an enormous achievement.
Now you had something that worked, something that could prevent this death or these deaths, which are respiratory deaths.
The last death was in 1974, and after that, there were decades where there were no adenovirus deaths in the military. In just a few short years, we went from adenovirus being a major problem that caused outbreaks constantly to almost completely controlling them, such that there was a really big change in the experience of people who went to boot camp. The Department of Defense partnered with Wyeth Pharmaceuticals to produce the vaccine. The Department of Defense was the sole customer, the sole purchaser, and Wyeth Pharmaceuticals was the sole producer.
So the adenovirus vaccine was a niche market. The niche market was the military. So the military or the government had to be willing to back that up.
If you don't have more than one manufacturer and something happens, it could be a mechanical problem, it could be a labor problem. We always consider that to be a vulnerability, because if Wyeth stopped producing for any reason, there would be no vaccine.
In 1984, the Food and Drug Administration issued an unflattering inspection of Wyeth Pharmaceuticals. Basically, the equipment that Wyeth was using to manufacture the adenovirus vaccine was badly out of date, and they needed to upgrade it if they wanted to continue that production. Wyeth Pharmaceuticals was not going to do this on their own time. They are a business. And so they went to the Department of Defense and asked for $5 million to make the needed upgrades so that they could continue producing the adenovirus vaccine.
The military has to prioritize this, but in order to prioritize it, they can't put the burden entirely on an industry.
There was at least one effort to get a line item into the DoD budget for the vaccine. That failed. And there was at least one, perhaps a couple of efforts to find a new manufacturer, and those were not successful.
$5 million is a lot for the average person, but for the Department of Defense, that's the kind of change that gets lost in the couch cushions. This is a very small investment compared to the department's budget. It's not completely clear what happened on the Department of Defense side that allowed for this lapse, but the Department of Defense was not going to make the investment needed to keep this vaccine going.
When I was sitting in the office of the Army Surgeon General from 1985 to 89, from my perspective, the adenovirus vaccine was doing great. I never saw anything that would make me think that it was in serious trouble.
At some point, the military public health people got wind that the adenovirus vaccine was on the ropes.
I was sitting at my desk at Aberdeen Proving Ground, Maryland, and my colleague, Dr. John Brundage, came in and he said, "Did you know that Wyeth stopped producing the adenovirus vaccine?" I was astonished. I couldn't believe it.
In an effort to try to save the adenovirus vaccine, they traveled to Wyeth facilities.
Several of us, all senior physicians in preventive medicine in the military, drove up to Marietta, Pennsylvania, and we were led into a big conference room. We sat around the table, and the director of that plant came in, and he was carrying a large stack of papers. And I could tell when he entered the room, he was not a happy person. And he took that large stack of papers and he threw it on the table. And he said, "I have been telling the Department of Defense for 10 years that we cannot continue to produce the adenovirus vaccine under current conditions. And these are all the letters that I sent. And your coming here today is the first response I've ever received from the Department of Defense."
After that meeting, it was clear Wyeth had stopped production and there was really no easy way back. And so the DoD was on its own. It had no choice but to face adenovirus without the vaccine.
From 1996 to 1999, we continued to use whatever vaccine was left.
The stockpile only lasts so long, and stockpiles have half-lives. They're not forever, so there will be a time when there's no vaccine.
Epidemiologists in the military made some changes to when the vaccine was given to prioritize the times of year and the populations at highest risk.
So it's sort of this Sophie's choice. I mean, who do you vaccinate and when, knowing that you're not going to be able to vaccinate everybody? Or said another way, who do you leave vulnerable because you have limited resources?
And so there was a bit of an interstitial period, but by 1999, there was no more vaccine left.
My colleagues and I decided we had to do two things. One, we had to set up very good surveillance systems to track what was going on, and we had to start briefing the leadership. And the idea was to not let this problem disappear. So we got the surveillance system moving, but then when we started briefing people, they said, this is a big problem, it's a serious problem, but none of them wanted to take it on. Colonel Charles Hoke was briefing a general, and the general acknowledged that it was a big problem and it was a serious problem. But he told Charles, it's not my problem. And Colonel Hoke very politely asked him, "Sir, would you be kind enough to tell me whose problem it is?" And there was no answer. The situation was very frustrating at times.
It was a complete throwback to the time before the vaccine was ever available. There were huge outbreaks in the barracks that took out sometimes a quarter of classes of new recruits. Some had cold-like symptoms, fever, cough, sore throat, but very quickly there started to be cases of severe illness.
There wasn't much we could do. Some places reverted back to old methods.
Containing outbreaks when they begin by separating the sick from the well, paying attention to bed spacing, so not letting people sleep too closely, hand hygiene, kind of all of the basics. But you have to remember that these new recruits are living together, sleeping together, training together, eating together. It's very hard to actually separate people effectively to stop chains of transmission.
And then in the year 2000, we had a death in a Navy recruit at the Great Lakes Naval Training Center. And this ended up in a story in the Wall Street Journal. The military had not seen a death from adenovirus in 25 years, and it was shocking. It was shocking because it ended up in a major newspaper, and clips from major newspapers end up on the desks of leaders. Early in my military career, I had an older fellow who was an interpreter, translator for me, and one day I was really frustrated, and he said, "Doc," he said, "you have to understand, people can see a problem in their mind, they can understand that problem in their mind, but until they feel that problem in their heart, they're not going to do anything about that problem." By that time, we had some people up at Fort Detrick who were responsive and said, "Okay, I'm beginning to feel this problem in my heart, and I'm ready to do something about it." We saw the Armed Forces Epidemiological Board getting more involved with what was happening with the adenovirus vaccine. We saw the National Academies of Science getting more involved.
Letters were flying, reports were being issued, meetings were being held, all really in service of finding a way to bring back this vaccine.
If you let a vaccine die and then you try and get it back, you're essentially creating a new product. You are. The FDA will view that as a new product, and you therefore have to subject it to the rigors of new product development. It's an enormously expensive effort.
Finding a new manufacturer, doing clinical trials again, getting quality control in place, and really starting from scratch.
People like Colonel Charles Hoke and Clifford Snyder had to come up with a process where they essentially took that vaccine with the same concept of using an enteric-coated tablet, but looking at new innovations in production and new rules as far as what had to be done, and put that into a plan to get a new vaccine. And that new vaccine was not fielded until 2011. So there was about 11 years of intense work there to get that vaccine out to the field.
So what started as a $5 million project in 1984 became a $100 million project to establish new vaccine lines in the 2000s. And it wasn't just the cost of manufacturing. It was also 10 years of millions of dollars in costs caring for troops who fell ill and having to restart their training. That was something like $250 million. And so when you compare the cost of prevention with the cost of starting from scratch, it was an enormous burden of money.
The vaccine was introduced, and almost immediately we just saw the respiratory disease rates plummet. And we documented that, and the effectiveness of the vaccine continued.
In the 12 years where there was no adenovirus vaccine, 8 young people lost their lives. The average age of people who died was just 21. And there were 4 who were still in their teens. They were 18 and 19. And when you think about what it means to have a young family member join the military, you worry about things like combat, dangerous training. You don't really worry about outbreaks. But what's particularly striking and sad is had they joined just a few years earlier, they wouldn't have faced any of this.
It breaks your heart because you know this was a preventable death. And that's what I think is going on right now with measles.
January of 2025, we ended up with one of the largest measles outbreaks in the United States in our backyard.
The measles vaccine came in 1963. At that time, there were 3 to 4 million children who would get measles every year. there would be 48,000 children who would be hospitalized with measles from severe pneumonia or dehydration or encephalitis, which is inflammation of the brain. And 1,000 children would get that encephalitis, a quarter of whom would be left permanently blind or deaf.
In 2000, the United States officially eradicated measles, which meant we did not have circulation of measles within our population.
The most contagious disease of humans was eliminated by the year 2000. That is a remarkable accomplishment. But now, a critical percentage of parents are choosing not to vaccinate their children against measles, and so measles has come back. And this year, it's come roaring back.
The number of cases just exploded exponentially, very, very quickly. We went from, 1 case to 10 cases to realizing there were a lot of sick children in this adjacent community.
When you are in a cycle of neglect, it's really easy to forget what it means to live through an outbreak, an epidemic, to face a public health crisis. But when you allow that neglect to pull back on the very control measures that are enabling that success, you're going to see a resurgence. You're going to see that threat come back.
We started seeing sick children that were infected with measles. And those children had very, very high fevers, a very painful rash all over their bodies.
We've had 2 children die of measles, healthy little girls, 6 and 8-year-old girls in West Texas. Those are the first child deaths from measles since 2003. That's more than 20 years ago.
This is the biggest year for measles outbreaks since we eliminated that virus, and that is directly due to fewer people vaccinating their children for measles.
It does sound an alarm, a warning bell that here, we're responsible. We've chosen not to give a vaccine that could have saved a life. And how many vaccine-preventable deaths are okay? None. And I think 1 is 1 too many. We live in a society that clearly benefits from technology and science, that knows little about science and technology, and is perfectly willing to set it aside. Let me put this in perspective. Cavemen lived till about 30. By the mid-1800s, people lived till the mid-30s. So from caveman times to the mid-1800s, we picked up 5 years of longevity. Now we live into the 70s, 80s. Why? Largely because of vaccines.
One of the reasons it's so difficult to tell the story of public health is because when we do our jobs right, nothing happens. And that's doubly true of vaccines. When vaccines are working, the diseases that they prevent are not in evidence, and that makes it really easy to forget how important they are.
We become complacent. We don't see these diseases circulating anymore. And people are like, well, then I don't need to get vaccinated.
And I think you can show them the data, but again, if they don't feel it in their heart, they think, well, that isn't going to hit me.
Even if we have more exemptions and allow people to make choice, we still need to have people be able to make that choice and have access to the vaccinations.
The adenovirus story points to the vulnerability of vaccines. And they are so vulnerable that you can lose them. And when you lose them, it's hard to get them back. And I feel like the adenovirus story is just a warning, essentially, for how bad this could be. That was one product made for one niche market. But the other products are made for all of us. And could we lose them? Yes, we could lose this. And our children will suffer.